All right, we're back with a new episode of Real in the Field, and today we talk to Dr. Tejave Sherifan.
Yeah, and he takes us through his journey from a personal trainer, high school football coach, and then eventually becoming a doctor.
Yeah, and then we touch on his experience working in a hospital during the COVID pandemic, and then he gives us his views and insight into the medical system.
Then we play a fun game at the end where we try to stump Dr. Tej and give him some real and fake diseases and see if he knows the difference.
Yeah, so sit back, enjoy this episode. If you like what you hear, like and subscribe, and enjoy the show. All right, we are back with a new episode of Real in the Field, and we've got a new guest today. Dr. Tejave Sherifan is here. Thanks for being here.
Thanks for inviting me. Glad to be here.
All right, so little backstory. We used to coach football together, and then I had to go to a different school, and then you went a different path. Stayed in touch. We text for a little while, and then next thing you know, you hit me up and you say you're a doctor.
Yeah, definitely taking the road less traveled. It kind of goes back to, I was a kid, and looking back on it now is a little bit of a flippant comment by my dad, but, he said something along, and it was in Farsi, it was another language, and he said something like, his doctor saved his life. And my dad was not an unhealthy person. He just had diabetes, but it was just something that I think, sticks with you as a kid.
Yeah.
And at 18, I was working out a lot, playing high school football, and 18, my athletic career, as illustrious as it was, comes to an end, as most people who play high school sports do. And one of the personal trainers who kind of knew me a little bit, he grabs me and he's like, "Hey, one of the personal trainers quit. Will you train this person real fast?" And I was like, "I don't know what I'm doing." He's like, "Doesn't matter. Just go through all the machines and just go down the machines all in order." And so I did that. We just went leg extension, legs curl, leg press, and then just went down all the machines. And then at the end of it, he hands me $60 cash. And, in 2002, you hand an 18-year-old, that kind of money. It was kind of hooked.
You're swimming in it.
Yeah, exactly. Stoked. So that took me down the path of, kinesiology and strength and conditioning and all those types of things, and kind of was a little bit of a inroad or an introduction into, the sciences of the body, like biology, chemistry, physiology, change, health, those types of things. So those two combinations of like that moment with my dad, and then always thinking about wanting to be a doctor, and then learning all those sciences, I always had that kind of vision for myself. And I think it wasn't until we went to one of those coaching clinics, and I don't know if I've ever told you the story. I went to one of the strength and conditioning clinics, and I talked to Chris Carlisle.
Okay.
He was the strength and conditioning coach for USC during the Pete Carroll days.
Oh, the bald guy.
Yeah.
Yes.
So, and he was very warm and very inviting, and stayed to and talking. And I think I ended up picking his brain, and through Cal State Fullerton, got to like work with him for shadow him for a week.
Yeah.
And got to know him, and went up there and saw everything going on at USC and what they were doing. And I was talking to him, and as I got to know him, I started talking to him about the life of coaching. Especially at that level, that was the pinnacle, was going to be strength and conditioning coach, NFL team, college team.
Yeah.
And I started talking to him about what his life has been. And, he said basically in the last 10 years, he had been at 7 different places.
Wow.
Dude, that's why I didn't go the college route. People tell me all the time, "Oh, why don't you go coach in college?" No.
Yeah.
No, thank you. You
Travel
lose and you are out.
Yeah.
And you're
On to
picking
the
your
next
family
one.
up and you're out. Yeah.
And speaking of family, that was the kind of, what really sealed it for me. He was talking about, I forgot now if it was his daughter or if it was his son, but that she's completely withdrawn, like doesn't socialize, because like every 2 years they have to pick up and move. So she kind of has this, thing of aversion to, socializing, because that's incredibly painful for a kid. First grade, second grade, you make friends, and then boom, you got to go to a new school.
Yeah.
And then, I think as I kind of matured and, you become like 27, 28, you're like, what do you want out of yourself in life? What do you want to make of yourself? What kind of challenges you want? And then I always had that vision of, that conversation of how impactful that was for my father to say something like that. And I wanted to get into something that was an act of service and that would still be along the lines of what I was doing, which was, helping people live a healthy lifestyle and, getting healthy.
What was it about your dad's situation when he makes that comment, because that's a pretty heavy thing to say, so that person saved his life, and saying that he's otherwise like healthy, like how did that doctor save his life?
He just diagnosed his diabetes.
Oh, I see.
Which for my dad, who has like a limited understanding of medicine at that time, like that was pretty significant. Now,
Yeah.
in retrospect, looking back at it from now,
Yeah.
like and now what I know what real disease is like, it wasn't that big of a deal. My dad was just thirsty all the time, feeling tired, and like
Yeah.
had all the signs and symptoms of an early diabetic.
Yeah.
And so, to him it meant a lot.
Yeah,
In the
yeah.
scope of medicine, it wasn't really that impressive.
But even still, something that changed his way of life, which ultimately would change. I mean, because that undiagnosed and untreated it could be deadly for sure.
Oh, absolutely, yeah.
Wow, that's pretty. I mean, that's stuck with you from that moment, like him having that kind of feeling towards doctors, that kind of stuck with you.
And that was just something that, if I could give that gift to somebody else or somebody else's family, let them see their children, grow up, get married, or, kids getting to see their parents around longer, that, it's a huge act of service that I just really wanted to participate in.
Yeah.
Okay. So you make the decision, and then you're on your way.
Yeah. And honestly, not really knowing what I was getting myself into was probably one of the better things, because it ended up being so daunting at every turn.
Yeah.
And it was kind of one of those things, well, I shut all the doors behind me, packed everything up, quit everything, and there's no going back now.
Yeah.
But if I would have, what I talk about a lot with some of my colleagues is like, because I didn't have any doctors in the family. I didn't really know anybody else that was in the medical field. It was just an adventure that I wanted to go. And if I would have really sat back and looked at what the next journey over the next basically 7, 8, 9 years would have been, I don't know if I would have gone down that road. But
what does that journey look like? What is that? How do you start off, and where's the starting line? If you're like coming out of the starting blocks, where's that, and what's that path look like?
Especially from my path, it was so unconventional, because you don't have a lot of, basically 28, 29-year-olds deciding to go back to med school.
Yeah.
It's usually a very linear path for kids. Their parents have ingrained in them that they're going to do well in school, and that they're going to do, well and study hard, get grades. So high school, it's always valedictorian, be the top of your class, get into, a good university, study pre-med, get all that, take the MCATs, yada, yada, yada. So I was probably 6, 7 years out from undergrad. And, the med schools just looked at my curriculum and were like, we don't even know if they teach some of this stuff that you learned. Especially,
how old are you?
Yeah, exactly.
You got a birth certificate?
Yeah, I am 12. So I had to go back and do what they call a post-bac. Okay. And so I did a post-bac at UCI, and and it was so hard. It was so hard because they gave all the priority to the enrolled kids and everything. And I was just crashing classes. And
what is the post-bac, just for people who don't?
Post-bac, is a post-bachelor degree. Okay. So for people that didn't have all of the basic sciences that you need for medical school, they have programs where you can go and instead of getting another degree, you just take the core sciences that you need to qualify for med school.
Gotcha. Okay.
Again, biochem, chemistry, biology, anatomy, all those types of ologies and all of those things that you need to qualify. So I had to do that at UCI, and that was good because that kind of prepped me for what I wouldn't need to learn how to learn again.
Yeah.
Because it was so long that you have, had your head in a textbook and trying to memorize things and conceptualize things. So do that, get that done, take the MCATs, find a school that'll accept me. And luckily, there was a school down in Florida that was open to like my non-conventional path, and it was like, hey, this just means you're a little bit more mature. You really want this. We have a lot of people that just are kind of going through this because this is the next academic step. And then it's, it's 4 years of medical school. The first 2 years are just brutal academics, just brutal, 8-hour lectures, not one, but 8 hours of lecture a day, and just moving.
And so you're living in Florida.
Yeah.
And
at 31, 32.
And so what, like, is it its own campus?
Yeah.
Like, you know what I'm saying? Like,
so
it's not part of like Florida State. Like, it's
no.
literally its own thing.
So part of the school was also in the Caribbean, so that way you could like get around certain things in terms of seeing patients and prescribing medications, because you're not board certified. But then these places in the Caribbean, they don't have any medicine, so it was like a way to work
Kind
with
of practice
medicine.
Yeah,
Exactly.
yeah.
So
There's a need out there for
yeah. So we're like bouncing back and forth between, Florida and the Caribbean. But anyway, so the first year is classroom, all classroom. And then like a little bit of, what they call like physical exam skills, like like how to do a stethoscope, how to auscultate, like palpating on the stomach, those types of things. But it's mainly just to kick your butt academically. Second year, same stuff. Then in your third and fourth year is your clinical years, where you now will be at a hospital and you're doing like in-hospital learning. So it's a combination of the core disciplines: surgery, internal medicine, pediatrics, OB-GYN, family medicine, and psychiatry. And it's either 4 or 12 weeks in each one of those. And you follow around residents and other doctors, and they give you, depending on where you do your training, you have different level of participation. Sometimes it's just purely observe. And then some of the other places, like you're in the surgeries, you're retracting, you're holding certain devices, you're putting in notes, you're helping write up like assessment and plans. So it's varied, but that is on the job training. And then on top of that, you still have lectures, tests, and curriculum on top of it. It's just scaled back now because you're spending 8 hours at the hospital.
Okay, let me ask you this, if we can go back a little bit. So once you're in and you're at that school in Florida, are they working to get everyone through it, or are they still trying to weed some people out?
No, and that was actually one of the toughest things that I had gone through. Is med school is, if it's fair to make the analogy, it's like a crucible of education. I kind of made the analogy of it's education buds training for Navy SEALs. Like the goal is to see who's not committed, who doesn't have the talent, and who we can separate, and not really bought in.
Yeah.
I mean, you're talking about.
I think that's fair. Yeah.
Yeah.
I mean, because you think about with buds training, they're trying to do exactly that: weed out the people, because this job is so demanding that you need this level of not just how book smart you are, but the kind of stress that you're going to be going through on a day-to-day basis. So it's a good way to weed those people out who can't take it.
And you're talking about tests where like the average mean, and these are people that are in med school that are smart and then know how to study and take it serious. Like the average mean on the test is like 65%, 55%. So it's a constant hit to either your ego or your self-esteem of like, I am busting my, like really putting in 16-hour days, 18 hours days, getting like 40% on tests. And then it gets curved and, it's appropriate, but you're also just constantly like, how I looked at everything, I've studied everything. How is this test still this hard?
Why are the tests so hard then?
I think that's just the way it is.
Well, how much of that do you see?
I don't have a good answer.
But how much of that test do you see in the real world? I mean, are these just like very like stuff that you won't ever like run into, or is it actual practical everyday stuff that you utilize?
I'll tell you, when I did my post-bac at UCI, we were learning organic chemistry, and anybody that's done organic chemistry, it's this annoying like arrow pushing thing, and it has like no real world practicality unless you are going to be a chemical engineer or whatever the case may be. And I remember a kid asking like the teacher, what's the practical application of this? And the teacher just flat out basically said it's to keep dumb people out of med school. And there's so many straight up. That's what, and like OChem in particular in the med school world, like OChem's called the dream killer. Because like everybody wants to be a doctor until you get to OChem, and then that really weeds a lot of the people out before you get to med school.
Would you say that's the hardest and that's the most?
No. I thought OChem was relatively not that bad. I didn't understand the hype about it. But going back to what you were saying about, I mean, there's like a whole curriculum in biochemistry.
Yeah.
Where it is really important. And biochemistry is essentially the molecular level, what's going on inside your cells, which obviously is super important and it's good to understand. it's not been a part of my actual practice one time.
Really?
Like ever. Like learning all of these intense, energy pathways like glycolysis, ATP, like some of the stuff that you're familiar with. It has come up like once, and like if like where I can't figure out what a patient has, and I go, well, if you think back to like glycolysis right now and the regulating step of this, oh, that's what it is. Like it has no bearing, and it's a huge part of the curriculum.
Yeah. Is that another thing to weed out the dummies?
Yeah. It just I don't know if it was because at one point it did lead to a part of medicine that you needed to know, and it helps you. I think that kind of stuff, it ends up helping you understand pharmacokinetics for some of the medications that you're going to be prescribing. So it's all just foundations that they build on. But yes, there's a lot of things that you learn in medical school that do not show up when you're actually practicing medicine.
Well, what was, if you had to like pinpoint one, like the most challenging thing that you experienced during med school, like what would that be? I
would, besides like some of the different subjects, I would just say it was the constant hit to the soul of like, am I good enough?
Yeah.
Is this going to work out? Do I know what I'm doing? How hard everything was, the volume that it kept coming. Those types of things of just really testing how bad you wanted it.
Yeah. Was it like once a week ego shot, or was it?
Well, it would be with the test. It'd be like probably every 3 weeks, every 4 weeks when we had some kind of
just that constant wave of doubt, pressure, doubt, and ego.
Think about, and I mean, you kind of experience it too through football. Like think about putting something like 16 hours a day, and it's your primary focus into something all day, and then just getting like either mediocre or above average results.
Yeah,
it's hard to keep going, and then every once in a while you get like a A or whatever, and it's like that'll juice you up.
Keeps you going.
It keeps you going.
Okay, so the 2 years are a lot of school, and then the last 2 years you're doing your
clinical
stuff.
Okay, so you're on site training. So you're in a hospital.
So was that at
Bakersfield?
Yes. Okay.
So that's when try to come back home. Family's here. Luckily, through my school, we had a really, really amazing training program in the jewel of California, in the high desert, Bakersfield, California.
If you've never been there.
If you've never been there, check it out. I hear right now is a good time to visit Kern County, and I'll be forever grateful for that opportunity that they gave me, because I ended up actually staying there and doing my residency there. But it was great for students because it's a county hospital, and in county hospital things.
Oh, you see the worst of the worst.
You see the worst of the worst, and it's kind of anything goes. So like the students have a lot of tangible experience, let's call it.
Yeah.
So
very hands-on there.
Very hands-on, very involved in the medicine and the patient care. And so that was good training wheels. You basically get there before all the other doctors do.
Yeah.
And the way that Kern has it set up is you do every single thing that the residents are going to do. You just do it before them.
Oh, okay.
And then you tell them what you did and what you think, and you act as them.
Wow.
And then they give you feedback in terms of like, okay, you're right about this, you're wrong about this, did you think about this, blah, 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 blah. And then the residents go do what they're supposed to do, and then they will then also present to an attending physician who's the board certified, has gone through residency. And so it's a nice kind of, I guess stepwise progression of, going as a student, getting your training wheels, and then residency, and then attending. So some of the things that you do as a medical student, like you will be doing in residency, you evaluate the patient in the morning, you do your physical exam, you look at the lab results, you look at all the test results that you ordered the day before, all of the consults, and then kind of aggregate that information, and then now make a new plan going forward. I think we should tweak this. I think we should do this. This patient just needs this. And then you tell the resident, and then the resident goes, okay, that was good. Did you also think about this?
Okay.
And so then that way, when you get into residency, you should be, kind of hitting the ground running, although you get in the residency and it's a whole new ballgame as well.
So at what point in this whole process do you pick, because you're an internalist or
internal medicine internist, yes.
Okay. So at what point does someone say like they're going to be an orthopedic surgeon, or someone is going to be a this or a that? Like what point in the process do you have to make that decision?
So when you're done with medical school, well, actually, so your third year is all mandatory curriculum. You have 12 weeks in general surgery, or you have 12 weeks in surgery. And so in that, depending on your program, your surgery program may be able to expose you to orthopedics, may be able to expose you to plastics, may be able to expose you to all the different types of surgery. But you have 12 weeks to get that exposure to see if that's something that you want to do and that's something that has your calling. I'll tell you this. The majority of people get into medical school thinking they want to be a surgeon, and then they do their surgery rotation, and they say, no, not for me, not for me. One of my roommates in Bakersfield, he came in, he's like, surgeons are, they're the real they're the real doctors. They're in the operating room, you're inside of the body. And I had already done general surgery. And he's like, yeah, I think I want to be a surgeon. He does his general surgery rotation for 2 days, and he goes, fuck surgery. I was like, okay, that changes quickly.
Okay, so why did you go the route you did then?
So I did internal medicine. So you do general surgery in 12 weeks, 10 weeks or 12 weeks of internal medicine, 4 weeks of OB-GYN, 4 weeks of pediatrics, 4 weeks of family, and 4 weeks of psychiatry. Internal medicine was the best for me because I thought it's every single internal organ. So brain, heart, lungs, liver, kidneys, anything in the stomach. So the variety and the depth is there to keep it interesting all the time. And you there's so much to learn. Some of the other things get like a little stagnant and it's the same thing over and over and over again. Internal medicine also then allows you the most amount of fellowships, which is the next level of how you specialize after residency. So you have to do an internal medicine residency to become a cardiologist, to become a nephrologist, to become, those types of things. It was a way to see, like, let's go down this road. You get to be a hospital doctor with internal medicine. That means when people get admitted after the ER, after the initial, triage, then they come upstairs and they get hand over to an internal medicine doctor. And so you take over the patients that are admitted in the hospital, and it's just such a wide variety of different diseases and treatments that it's going to keep the job fresh.
Yeah. How does that look like when somebody comes in and you're starting to diagnose them? How do they tell you their symptoms? Like, how does that process go, and how do you start to kind of frame what their could be?
The really challenging thing that I don't think med school does a good job of like with all of our practice cases and all of these, everything is very typical, let's call it. So it's like a very typical presentation. When you start talking to people and you're trying to elicit a history from them, their like vocabulary or the way that they explain things is not like what you've practiced. So like a lot of the things that I'll get is, so for a heart attack, like all the times on a test, it's like sternal pressure, feels like elephant sitting on my chest, can't breathe, hurts when I exhale. And it's just like when you start reading that, right away, like that's a heart attack. Yeah. You'll go talk to someone, they're like, I got this thing, I don't know. It kind of like, it's like a sensation. I don't really know how to describe it. And you don't know if they're talking about their lungs, their heart, they have acid reflux, whatever the case may be. So the key is, am I asking the questions the right way to get information that's useful to me?
Yeah, interesting.
That's what I like, trying to use people skills and trying to like assess the person and then like giving them specific examples so that I can say, okay, he's talking about, typical chest pain, or this is more GERD, or this is more lungs, those types of things. So
does that change patient to patient?
In what sense?
Like in the sense of, say I come in
question.
And I'm like, your question. And I'm like, oh man, like this or whatever. Like, are you going to approach me different?
Yeah.
Then
you would say like, hey, is a lineman sitting on your chest?
No, you know what I mean though?
Yeah.
But like, so you even patient to patient, you have to be able to.
Oh, absolutely. Yeah. Okay. That's the first thing. It's just like, it's like trying to work and figure out what vernacular gives me the best useful information to help me get the history that I want. And this was something that was harped on us all throughout med school. And now that I've actually been practicing, it's like, it's very true. Like, everybody wants to go straight to the test. You want to go to the EKG, you want to go to the labs, you want to go to the imaging. And if you do this enough, you can get everything you need or everything you want from a good history. Like, because the disease processes are so, medicine's been around for so long, like you can get a lot of useful information from an accurate, good history. It's just difficult because people's way of describing or people's knowledge of what's going on in their own body is so limited that it requires a little bit of like finessing the situation.
Or they don't want to tell you.
Yeah, that too. It's been really shocking, like how many people don't have a good grasp on their own medical history. You know, I'll ask, and that's a big part of this whole patient-patient interaction is like, okay, trying to think in my head, like, what has this person had in the past? Like, what could this be? And I'll have men in particular, like men at this are the worst. I'll have a guy, I'm like, okay, so like, what's your past medical history? And he goes, something with my heart. Okay.
What is that something?
Okay. And he'll be like, yeah, something happened. I was in the hospital. I'm like, okay, that could be anything, right? Who knows? He had palpitations, this, that. I go and like open up his gown and to like, you know, auscultate, and he's got a huge zipper scar from a sternotomy, and like, you know what I mean? And it's just like, well, could you tell me that you had like crash open heart surgery, you know? So that's kind of where I go first, is like, make sure I can get a good history, and then that'll dictate everything else of like my algorithm for diagnosis.
Yeah, you can tell a lot from the history.
Yeah. What are the ailments that you see like the most? And do you ever second guess your like diagnosing?
So first question, I'd say the ailments that I see the most is heart failure, which sounds scary, but it's just basically the heart's a muscle, and it has a strength of a squeeze, and that's measured by something we call ejection fraction, which is, and this is getting in the weeds here, but basically like how much blood comes in and how much blood you actually squeeze out.
Isn't that your like and diastolic and or what?
Yeah, so that number.
That takes me back.
So
your stroke volume? No.
So yeah, essentially close. It's the fraction of, it takes into consideration the stroke volume, because what matters in the stroke volume is actually how much, before you measure the stroke volume, how much blood came in.
And systolic and diastolic or something. Yeah.
So so he plays the part. So
dude, Russian back right here.
So how much blood comes in versus when you squeeze, how much blood comes out. And that's called an ejection fraction. That's why it's a fraction. And then that gives you a number, and anything below what they call 65 to 60% is considered heart failure. Now there's different levels of that. You can have, I've seen people like 5-10%. And so basically, instead of having like a strong squeeze, you just have this like weak heart that's just kind of fluttering like that. Yeah. I'd say that's the most, and then still, because of the generation before us that smoked, a lot of lung, COPD, asthma, those types of things, I'd say were the most. I think one of the misconceptions that I had when I got into medicine was I was going to be treating these like really unfortunate people that just had this like horrible thing happen to them, and it's just bad luck. And what I was not ready for, and what I was prepared for, is the overwhelming, and this is purely conjecture, just throwing numbers out, the overwhelming amount of admissions or disease processes are all lifestyle based.
Really?
Yeah. It's very, very interesting to have like a peek behind it. Like, so much of our sickness
is self-induced.
Is self-induced.
What does that do to you as a doctor, like doing your job day to day? Does it have like an effect on like your view on people and patients?
It breaks your heart.
Yeah.
One, and then two, it's my job to educate.
Yeah.
I mean, a lot of times, you'll tell people, and I still struggle with this a lot. Like, people will just overeat, be sedentary, and eat the wrong things, and then you say your kidneys failed because of this, your heart failed because of this, and they'll really be honestly blown away. Yeah. They're like, what do you mean? And just a lot of people, I don't know if it's because growing up in South Orange County, and it's very like health conscious and whatever the case may be, but there's just a lot of people that think that they just didn't know that sitting around drinking this much soda, not moving and not exercising was going to lead to this much internal damage.
Yeah. Yeah. It's heartbreaking, and seeing it just with people that we know, and you just kind of look. I mean, it's easy for us to kind of look over and go, "Man, hey, kind of get your shit together," but you're dealing with it like you're having to fix it. You're having to fix it on a daily basis, and when they're coming in, do you see patients that come in like
all the time? Yeah,
same thing.
Yeah, frequent flyers, and it's the same thing. They can't kick whatever it is that's doing the damage to them, and it's just too hard for them to make that lifestyle adjustment, whether it's over drinking alcohol or overeating and not controlling their diabetes, drinking too much soda, like whatever the case may be, because for a lot of people, when it's not, a lot of people just from the don't do drugs dare era think that the only thing that's bad for you is cocaine, methamphetamine, heroin, and all those types of things, and they're like, well, I'm not doing anything bad, I'm just I'm just eating stuff from the store. Like, how bad could that be? I'm not, a drug addict. And the answer is really bad for you. It still does a lot of damage.
Yeah.
That's crazy.
Yeah.
Man. That's good.
All right. Well, on that, on that downer of a note, we're going to take a quick break. We're going to regroup, and we'll be back after this. This episode is brought to you by Cigar Spots of Orange. Cigar Spots is located in the Circle of Orange.
They have all the top brands of cigars and accessories, including my favorite, the Tatuaje Black Label. What are you going with?
That's a good cigar. I'm going with the Padron 1964. That's a hard cigar to come by. All you cigar lovers know how hard it is to get that cigar. But they also do home delivery. You can actually place the order online and have it delivered to your home if you live within the Orange County area. Or you can go and pick it up in store. You can order online, go to the store and pick it up. I did that recently when we were going out to dinner, needed to get a cigar on the way out, picked it up in store, and I was off.
When you were online, did you enter a promo code by chance?
Oh yeah, put in that promo code Tony Joe, got myself 20% off there. So visit cigarspots.com, and like Joe said, enter that promo code Tony Joe to get yourself that 20% discount. All right, and we are back. All right, we got a question. What are some misconceptions about being a doctor?
I think one of the first misconceptions that I get is when people hear that you're a doctor, they automatically assume you're a surgeon of some type, and not really realizing that that's a whole specialty on itself. And so I'll tell people I'm a doctor, and they say, well, can you fix this and this? And a lot of people think when you're a doctor that it automatically means that I can do plastic surgery as well. It might be more optimistic, but I don't do well with my hands. I didn't like the operating room. I hated it. And so I would say the biggest misconception is everyone thinks like you're a surgeon, or you can work with your hands and cut people open, and that's what it means to be a doctor. I think one of the misconceptions that I had going into it, or one of the things that I wasn't really prepared for, is the business side of medicine and the admin side of medicine. Like, so much of what I'm harped on now as a professional is like my metrics. And it's getting a little bit better with patient satisfaction, but now with Medicare, all of that my bosses care about, not necessarily my doctor bosses, but the money people in the hospital, is my case medical index, my length of stay, and that's really all they care about. And now it's starting to get a little bit into patient satisfaction and that type of stuff, but I wasn't really prepared to have non-medical people have their input on how hastily or quickly efficiently my medical practice should be.
So what's the reason that I guess at the end of it, it's a business, and they have to keep the lights on, and they have to make sure that the costs are down, and make sure they keep the lights on. But what is it that they're looking for with your day-to-day patient?
So Medicare cut the spigot off. So what it used to be, and what the old timers always talk about, the good old days, was it was just an endless budget. Oh. So there was no rush to get people out of the hospital. There was, no hindrance on ordering whatever you want. Yeah. And then the budget, got out of hand, and
had to pull the reins in a little bit.
Pull the reins in, exactly, and just So Medicare and the government started saying, like, based on diagnosis, you get an allotted sum of money for that hospitalization. Does that make sense? So you come in with pneumonia, you get this amount of money. Now, what ended up happening is like that was too vague. So now they have this like case medical index where it's like, now I have to say, does this patient have severe pneumonia, pneumonia with sepsis due to pneumonia, severe sepsis with pneumonia with and organ damage, pneumonia with acute respiratory hypoxic respiratory failure needing supplemental oxygen. And these are ways that you can like not make, but this is a way that you like correctly
unlock some funds.
Yeah, exactly. You are accurately assessing the severity of the patient's disease, and then Medicare breaks you off a little bit more money because this patient's sick and needs a little bit more stay.
Right. So are the bosses telling you to like...
So we go over, that's like a big continuing part of my education, and this is where I think med school does a lot of people disservice, is like, and this is where you get your clinical training, they're talking about correct ways to code things and give correct assessments. Acute hypoxic respiratory failure, severe sepsis with end organ damage, septic shock, like all of these types of huge buzzwords to increase your billing. And so they're coming in, numbers people, finance people are coming in and basically kind of telling us what to do and how to word things and how to phrase things and how to document things. To get reimbursement. And that's the game now. And then that's what it is. I wasn't really prepared for all that because what the hospital wants is to get a big chunk of money, but then save money on how long you're actually there. Because Medicare is basing the cost on the average length of stay. So they're going to say like, okay, we're going to basically compensate you for what 5 days in the hospital should stay for. And then the goal of the hospital is they want you out by 3, so that like those 2 days that are left over, that's the money that goes to the hospital's pocket.
Oh, I see. So like we were saying, it's a business and they're trying to increase their profit margins by doing things like that. So the fight is between you and someone who is a numbers cruncher who maybe doesn't really know much about treating patients and what goes into it, and just that kind of almost like humanity side. They're just looking at it from the dollar the bottom line.
And they're just, and a lot of the people at the hospital are just the messenger. And like, and I have to be careful where I displace my anger. Like, so they'll tell me, oh, we only reimbursed you for 3 days for this. And I'll be like, but this patient was, this was wrong with them. This was blah, blah, blah. And it's a shoulder shrug. It's like, take it up with Medicare. Like that's what it is. Like Medicare only gave us 3 days of coverage for it. Yeah. And so, you got to, really, it's not a black and white issue because everybody complains about how high taxes are. Right. And like nobody really wants to pay 40% taxes, 30% taxes. So if, government spending has to come down. Yeah. And one of the places that they've learned to try to cut off the spigot, like I said, is Medicare. Yeah. And it's only getting less and less. The reimbursement's getting less and less and less and less.
Is it leading to like affecting you doctors to... I don't know,
it's leading to
being more like,
it's leading to aggressive discharges. So,
but not the actual like diagnosing part.
No, and it's tightening up the budget, so it's forcing you to be better, right? So when somebody comes in, I can't just go, oh, I don't know what's wrong with them, and let's MRI their whole body, right? Because MRIs cost a few $1,000s, and so it's forcing you to be better and be more efficient, which is a good thing. But it is forcing you to like aggressively discharge. And a lot of times people come into the hospital and they want to leave the hospital better than they came in. Yeah. Which isn't really realistic, especially in some of like our elderly patients where like one little UTI or one little head cold, I mean, that like a person who's in their 80s or in their 90s, it's going to take them like weeks to get back, if ever, to where they were. And a lot of people don't feel comfortable. Like, no, I don't feel good. I don't feel, and it's, from a hospital standpoint, is like, if you're done medically treating you, like the rest can be done at acute rehab or like home rehab, like you got to go.
Yeah. Wow. What, so, I mean, we've heard, and this is might kind of get off topic a little bit, but you've heard of like Medicare for all. Is that something that you think would be a solution, or would that be just kind of muck up the water even more?
It's all in how it's done, right? Like the concept of everybody getting universal healthcare is beautiful and it makes a lot of sense. Go talk to the Canadians that have it and see how they like it.
Yeah.
Especially where I practice, it's a snowbird city, and we have Canadians that come and they despise it.
Really?
Absolutely.
Interesting.
They absolutely hate it.
So what's the unintended consequence of having universal health care that maybe people aren't seeing when it's put into
The
practice?
taxes just like out of control.
Canadian taxes are close to 40 to 50% for everybody, and then the healthcare system, with the goal of getting more people healthcare, you're going to get more people in to the healthcare system. So you talk to some of the Canadians that have universal healthcare, and granted, if you get hit by a car and you end up on a ventilator and you're in a coma and, you're in the ICU for 2 or 3 months, they patch you together and they say, hey, we did our best, you're healthy, and boom, you don't have a hospital bill.
Oh, yeah.
And it's great for that. But you have like a head cold or you have something, wrong, and you want to see your primary care, you're talking like 2-month wait, 3-month wait. And then for any of like the diagnostic screenings, like your colonoscopy, your chest x-ray, all this type of stuff, 4 months, 5 months, like it's just so much slower.
Yeah.
And there's not really that much of, a little bit here in a capitalistic country, you can get like more of a kind of a premium product going to, people that have fee for service or, I charge this much, that much. And so it allows for a little bit more room in terms of, seeing different people.
Yeah. So the free market just allows for more, for a better service. Whereas with something that's just kind of like given, it just ends up being.
So there's incentives for
Or watered down.
Watered down
there's
version,
incentives for like the cardiologists and different people to like be a better doctor, and besides doing right with the patient, but like being a better doctor in terms of like customer service.
Sure.
Because, there's different billing rates and all these types of things. So, it's kind of capitalistic in an essence, and it just really, forces ingenuity and forces adaptation. So it's not cut and dry when people start talking about universal healthcare, and it will do a lot of good. It's just how much I don't think it's not as rosy and as amazing as people think it's going to be.
Well, no, it's an interesting perspective because I think that's a part of it that people don't understand or it can't kind of conceptualize that when you have so many people trying to get universal health care or go to the doctor at one point, it's like you're going to have a longer wait.
Right.
And here we have the luxury of, specializing in certain areas that kind of helps alleviate that traffic.
The other issue is like, does the hospital stay need to be $200,000, $300,000? Like that's another issue where there's probably a common middle ground between, Medicare for all, and then lowering the cost of how much medicine costs.
Maybe like a cap or something like that.
Yeah.
Well, what in thinking about that, about what the free market does for medicine, I'm sure it has an impact on like some medical advancements. Like what is going on in the medical world now? What are some of the advancements in medicine going right now?
So I'm not an expert in the surgery side because I'm not a surgeon, and they're doing different things all the time. Like one of the things that they're doing now for people with prostate issues is they're just introducing steam into the prostate, and that's doing a huge advance in BPH, prostate issues, and like men like having.
I want to know how they found this out.
Of all the things you could have picked,
right? So, it's a huge issue for a lot of men, and a lot of men don't want to talk about it. But like getting up in the middle of the night and urinating all the time, and then it affects your quality of sleep, and then with your quality of sleep, you feel low energy and all these types of things, and you had to take Flomax. And then they had this other procedure called a TURP, where they basically like burrow a hole in your urethra.
Oh, jeez.
So it's nice.
What are we talking about?
So it's nice now that you basically a little bit of steam, and they're getting good results with that. In terms of
how about anything
in the internal medicine?
Yeah, how about there?
No, hold on. I want to know more about this. Just
So my area of expertise is more on the internal medicine side. some of the better advancements that I'm seeing right now is more targeted therapies with cancer. Chemotherapy is going to be one of those things, and I can see it here now. Like chemotherapy through the lens of history is going to be looked at as just moronic and idiotic.
Really?
It's the only options we have now. But I think in 50 years, 100 years, or whatever the case may be, they'll look back at chemotherapy as like leeching or
really
just
or like when you used to see like cocaine and like cough syrup,
or like or just even like making like a witch making like a witch's brew and putting it like on a dirty wound. Like chemotherapy is so terrible, and really like the whole crux of chemotherapy is kill the body as much as you can without killing the person, hoping that you kill the cancer first.
Oh Jesus!
And like that's the best that we have right now, and it works. It does save people's lives, but like if you've ever had the unfortunate, God forbid, of somebody that you're close to go through chemotherapy, it's terrible. Yeah. It's absolutely terrible.
Okay,
well,
so
what's the alternative?
So now they have the like what they call targeted therapy, and like the movement in my field in particular is all genetics, because now we have like CRISPR technology. We've sequenced the human genome, and the genome is where everything is. Genetics is where everything is. So now you can look at these cancer cells, and the ones that have like unique specific gene mutations or different gene proteins, you can pinpoint that mutation and have a medication work to that, and then you're only killing cancer cells as opposed to like this mass.
Everything,
so it's like taking a Tylenol or an Advil for your headache, and it just specifically goes to like a pain receptor.
It's basically like, so you take the way that an antibiotic works is like you take an antibiotic that's targeted at that bacteria, and it's going to kill mostly just that bacteria, right? It doesn't kill your red blood cells. Right. It doesn't, it's not targeting that. So that's where they're really hoping to get to in a lot of the cancer research is, and so that somebody can take these medications, not be on their deathbed, and all of the cancer is gone. Yeah. So that's
really cool.
Yeah, I would really love for that to come sooner than later. And then, like I was saying, with the genetic stuff, CRISPR, which, you want to talk about playing God, you can do genetic mutation and take certain, harmful genes out, and then that way people don't have these hereditary genetic diseases. Whoa. But there's a dark side to that, which is like the
where do you draw the line?
Where do you draw the line? Do you start in like designer babies? Like they already did it in China, where like they basically put together the perfect genetics that they wanted. Wow. And so you can do basically get the movie Gattaca, like have the perfect genetics sequence.
Exactly what you want.
Exactly what you want. So that technology is already here.
Watch out.
What's the fallout? I mean, at what point, if you do manipulate like a gene like that, I can't imagine that there's not going to be some fallout, some unintended consequence, like by manipulating it, that it's just like free and clear, you can just kind of get away with it. There's got to be something,
right? And that's the process that they're working through right now. Is what can you do? What can you get away with? Because what's interesting, like they'll teach you in medical school, like the genome is like this linear thing, like with all the T, A, C, and G's and all this kind of stuff. But it's actually like this ball that has. There's a 3-dimensional concept to it, where the genes are and when they get activated. So by you doing genetic manipulation, you're kind of messing with the topography of that 3D shape. Yeah. And you don't know, like, even though you think you've targeted that gene and you've fixed it, you don't know what you've done to a gene that's folded, very downstream.
The butterfly effect.
Exactly. Very much so. So they're working through that progress. And and a lot, and that's why, in medicine, it's always a 10 or 20 year kind of evaluation of things, because you have to do your intervention and then kind of just sit back and wait and
watch the ripple effect and see what happens.
Wow. Well, speaking of that stuff, like, how do you feel, or what are your thoughts when people say, the science or follow the science and stuff like that? Because that term's been thrown around a ton.
Right. So my question is like, I don't really know how that's used in everyday conversation besides how it's used in my world, which is like when they say the science, we're talking about peer-reviewed studies from academic institutions that are published in like well-established, medical journals, and everything that we're taught and that we do is all evidence-based, science-based medication. It seems like now in society, there's a lot of people that will like to follow the science, and it's like, well, what's your scientific background? What are you calling science? Because in my world, when we say follow the science, we have a link to a study and, that's like meta-analysis and these types of things.
Well, they have a link too. It's just a Facebook.
Yeah, exactly. So that's the kind of thing that, because and to sound elitist, like the common person, when they say follow the science, you're talking about a link where you read an article and it says studies say that doing this does that. And it's like, well, okay, did you look into the study? Who did the study? What type of study was it? How many people were involved in the study? And there's so much that goes into statistics of like actually validating a study. Yeah. And the regular Joe Schmo or whoever just is saying like, oh, follow the science. Like, you don't really know what you're talking about. But in my world, like you don't deviate from the science. You do everything that's proven by science, that's been replicated. It's all evidence-based. So in my professional world, yes, we do everything by the science. But the way that you're phrasing it, I think you've had different experiences with people that say follow the science, and it's just a cool term that they like to put out there. And it's like, okay, well, give me the science to follow.
But then there's like,
maybe
because then terms have developed of like science denier or like whatever. And so I don't know. I just. Yeah. What are we talking about?
So someone is going to tell me, follow the science. Like I could quickly, okay, well, what science are we talking about? We're just talking about that you read 2 lines of a link that somebody sent you that said this, and
Well, that was like one of many things that came out of like pandemic 2020. But so, what was your experience during that? Because I mean, that was. That upended the world. The world just put on pause. And for us, like for everyday Joe Schmo, we weren't on the front lines like doctors were. So what was that for you?
A central theme, like for me and throughout my whole medical experience, like ignorance was bliss. Like the pandemic, my residency was actually defined by the pandemic. I started in July of 2019, and then by the time February, March 2020 came, I was in my first year of residency.
Oh wow!
So my whole residency was defined by COVID, and I got into residency. I'm going to treat sick people. I'm going to see people dying. I'm going to see diseases, and I didn't sign up to be a doctor and experience a pandemic, but I got it, but I didn't know what else there was to experience. For me, it was just everything was going to be brand new anyway. Dealing with diseases and, trying to save lives was going to be the experience anyway. I got maybe more so than other people would have before me, but that's their truth. And, my experience was what I went through the pandemic.
Man, if he could get through that, he could probably.
Yeah,
that's Diabetes Dave walking through. Exactly. Here we go again.
So definitely tough calluses, mentally tough, and I'll probably be paying for the PTSD of it, years down the road. But like I said, I didn't really have anything else to compare it against. So it was just, this is what it is. We're going to do it. We're going to try our best, and let's get through it.
What was it like in the hospital? I mean, not to, kind of revisit the whole kind of trauma of it all, but, what was it chaotic? Was it, was it everybody just kind of doing their job, head down, kind of going about it?
I would say it was very much like, not that I don't have any experience, and I don't want to, belittle anybody's, service in the military, but I would imagine it was the same thing of, here's this awful thing that we have to go through. Yeah. Let's make the most of it. Let's do it the best that we can. Yeah. And just keep fighting and keep fighting and keep fighting. Yeah. There were several times the hospital's full, we're running on supplies, and what are you going to do? You're going to throw your hands up and throw a huge pity party for yourself, and you break down. Like, people are looking to you to kind of keep your cool, lead, and be calm, and do your best. So there was no instances where you can complain, where you could, back down and just keep going, keep showing up, working.
Yeah.
And that's really all, that was my approach. And I don't know if that was, and thank God I had all of the athletic stuff to like in football and everything to fall back on. Cause I mean, that's really what sports and getting better at something is showing up, mentally tough, work, and get through it. Try your best, hope for the best outcome.
Is that something you think that background, sports background, gave you that just kind of like that edge or just that mental toughness?
I think so, because I some of the people that did have big issues with it and had a little bit of breakdowns, they didn't necessarily have a high competitive sports background, and I'm just one of those believers, that I think sports as a young adult just shapes you for life in terms of work ethic, discipline, mental toughness, those types of things. So I might be, prejudiced or biased, but I just kind of looked at it as, this is a tough opponent. This this COVID thing, especially in the hospital, is going to be one of the toughest opponents that I'm going to have. Yeah. And what can I do to defeat it? And it show up, get better, work hard, those types of things.
Well, we've talked about that before, about, mental toughness and just kind of pushing yourself to a limit, figuring out where that limit is, and then pushing yourself beyond it because you had no option, and I know, like, not to be, cavalier or to try to compare the two, but, when you're on that football field and you're just kind of digging deep and, think you have nothing more in you, and you push yourself to it because you have no other option, you have to run this, this next gas or whatever it is, and, transferring that onto your job where you had to do it. There's no second guessing. There's no nothing. You have to.
But with some of those like doctors that maybe didn't have that experience, like, I don't know, was there any like disputes between you guys, or was it more of like you had to bring them up and kind of pep
there
them
was
up,
a lot of
or
people.
Was it...
Yeah, there was a lot of people that tapped out, not like quit, but like needed a day or two, and then the people that did have the mental resolve to like pick up the slack, they were thrust upon their shoulders. And in all honesty, you don't want someone there that's like mentally breaking down. You want someone that's kind of keeping it together. So if they need to take a moment to gather themselves, then all for it. And like there was a core of us that were there, that because it was in the ICU where everybody would just be overwhelmed. There's only so much. And there's only so much people dying around you, and talking to family members and explaining to the family members, hey, we did our best, but it didn't work out. Your father's gone, your mother's gone, your loved one is passed, whoever it is. There's really only so much of that a lot of people can take. So for people to, break down and saying they need a day out, like day off, or, can't do it anymore, totally understand. For me, like I said, it's just showing up, mentally tough, like, if nobody else is going to do it, if I'm not going to do it, who else is going to do it?
That's some heavy stuff.
That's
and really heavy stuff.
Yeah. So I don't know if that was like my defense mechanism, if that was like where I went to make it work, as like, I just looked at it as, okay, I'm on the battlefield. I'm on the football field. There's no retreating. There's no giving up. I'm not letting this opponent win. We're fighting for our lives, and there's gotta go.
Yeah, deep. Yeah.
Dang, man. So that is crazy.
Yeah. Wow.
And I don't know if I would have had that without having experienced something like that through competitive organized sports.
Yeah.
Which is like, strapping everything up, and here we go. Are you going to quit or are you going to show up and you're going to be a gamer?
Yeah.
And then also just hard work, like, lifting, gassers, hard practices, 2-a-days, all those things. Like, I think, and it did something for me personally, and I'm forever grateful for it.
It's a good common theme that I think that we've, talked about in this show is, what that does to people, what that does to young kids in our formidable years at that, age, and how it's just so important, and it just sticks with you. It sticks with you for years. I mean, even to this day, when things get tough, you just kind of, think back to those times and how you felt and knowing that you can get through it.
And it's weird because they tell you that when you're doing it, when you're a teenager, and it doesn't
make sense.
And it doesn't make sense to you. And then here I am now, and it's like, yeah, this totally makes sense. And
still going back to it.
I'm probably like mentally tougher now than I was like back then, where it's like, oh, I don't want to do this. I could be at the beach. I could be doing this and doing that. But, I can't talk highly enough about organized, tough sports.
Yeah.
You know?
I tell my players that all the time. I'm like, I know it doesn't make sense right now, but you just gotta believe me.
Yeah.
Just do it.
It's gonna pay. It's gonna pay dividends.
just
It'll pay
do
dividends
it.
in your life.
So, but let's switch gears. Mm-hmm. Okay, I've prepared a couple things for you. This is a surprise for you.
All right.
We're gonna play fact or fiction with diseases.
Okay. I better get these 100%.
We're gonna see which
this
ones,
part can be edited, right?
which ones of these are real.
We went in the medical book and
Yes, I
looked up.
cracked open so many books here. First one, conjunctivitis.
That's real. That's
What-
pink eye.
Pink eye, very good. 1 for 1. Here we go. Keeping score. Here we go. Burkitis.
Burkitis. Bursitis?
No, burkitis.
I don't know what burkitis is.
Real or fake?
Fake.
That's fake. All right, here we go. Mononucleosis.
Oh, yeah, that's real. That's the kissing disease. That's what everybody gets.
That's mono.
Yeah, it's mono.
Gastroenteritis.
Yeah, that's-
there you go.
that's-
You jumped in for me. That one's real. Pigeonoma.
That's fake.
That is fake.
Pigeonoma, that's so good.
You know how hard it is to make fake diseases? I was searched so hard. I tried so hard.
Pigeonoma. What would it be though?
Well, yeah, so tell
Like
us.
What was
so,
pigeonoma
so
would have been.
pigeonoma comes from no.
You start,
It's when you walk,
you start thinking you're a pigeon.
or you
No.
walk pigeon toed like this.
Pigeon-toed.
I just got pigeonoma.
Oh man, you hear what happened to Bobby? Bad case of pigeonoma.
All right.
It's going around.
Yeah.
Here we go. Foreign accent syndrome.
Foreign accent syndrome. Now you're getting into the psych. I would say that is fake.
I want to say it's real.
It is real.
Okay.
Is
Foreign
when you wake
accent
up
syndrome.
from like a coma and you like have you speak with an accent.
Yeah. So you have some type of head injury.
Yeah.
And you can like.
Oh, I have
speak
heard
other
that. Yeah,
other
yeah.
languages.
Yeah. I wasn't. Yeah, I was talking about someone because there's like factitious disorders where, there's like conversion disorders, and sometimes people take on new personalities. So yeah, that one is real. Yeah, I've
Got him.
got me. You went psych on me, but yeah.
Yeah. Here we go. Acute andromeda.
Andromeda. No, that's fake.
Oh, dude, way to add the front
Acute,
part.
right?
I like that. I like that. I like that.
I
That's
tried
good.
so hard.
Yeah.
I got more. Here we go. Diverticulitis.
Diverticulitis. Real.
Okay, what is it?
Diverticula is so your intestines, your digestive tract is supposed to be a smooth tube, and then you have these like outpouchings in your intestine, and it's basically a bad anatomy where like undigested food or fecal particles can go inside of that outpouching, and then that diverticula can become inflamed, and then that becomes diverticulitis.
Ooh, how do you treat it?
Antibiotics, healthy diet, and then it gets bad. Like a lot of those times, those diverticula perf, and then
Yeah.
you need bowel resection.
Yeah. What do you got to stay away from like seeds and stuff?
That was always the common thing. It was like popcorn and seeds and everything like
Damn,
that.
how'd you know that?
I feel like I heard it somewhere. I don't know.
Brock Lesnar. This is what happened to Brock
Yes.
Lesnar.
Yes.
So he got diverticulitis and had like I think 2 feet of his colon or his large intestine removed.
2 feet?
Yeah, 2 feet.
All right. Labyrinthinitis.
Labyrinthitis, ear infection.
Oh, I think I've had that.
Yeah.
Labyrinthitis. Yeah.
Yeah?
You get like dizzy. Mm-hmm. Yeah.
Ringing in the ear, dizzy, nauseous. Those.
How do you
types
treat
of
it?
Well, there's a lot of different causes. There's like Meniere's, BPV. Sometimes it's like medication induced. So if it's an infection, you treat it with an infection.
Yeah.
If it's Meniere's disease, it's like lifestyle, and then if it's BPV, it's like these Epley maneuvers that you have to do and move your head, things like that.
Oh, I've seen that where you like go
Oh, the
upside
fluid
down.
in your ear.
Yeah.
And like you like,
Yeah.
yeah,
You
I've
have,
seen that.
The way that your positional sense, you have crystals inside of a free fluid
Yeah.
that has like zero gravity.
Yeah.
And so when you move, then it kind of like it positions in that fluid.
Yeah.
And that lets you know that you're upside down or you're sideways and those types of things.
gotcha.
So then what ends up happening is like, when those crystals are dislodged, now you just constantly think you're upside down when you're not.
Oh my
that's not
God,
technically
dude.
what labyrinthitis is, but that's like one of the symptoms of
Okay.
labyrinthitis.
All right, here we go. Fibromyalgia.
Oh yeah, that's definitely real.
Body pain, nerve pain.
Fibromyalgia, yeah, it's like an overwhelming like sense of like just pain without necessarily any eliciting factors.
Okay. All right. Resistant Gulf Ebola.
Now, Ebola is a disease, and then if you're saying that there's like a new strand of resistant Ebola, I would say possibly. Ebola is real. Is there new resistant Ebola? Let's say yeah.
Fake.
Got him.
Let's do. Okay, last one. Idiopathic adolescent acute neurodegeneration.
Is it real? It's real.
I thought it was fake.
Really? Okay. Because
I just started throwing really.
I was actually going to say.
I threw a lot of buzzwords together.
Yeah, exactly.
That's what.
You got me because it was so well put together. I didn't think you could come up with it.
That's what I'm talking about. That's what I'm talking about.
That was pediatrics. I'm not a ped doctor.
No, I got it. I got that from. I'm not even going to tell you guys where I got it from. But anyways, it's fake.
Yeah, got me. So it was the Fournier's foreign language.
Yeah,
Ebola, which was real, but then you added golf resistance. The really good one was that last one.
Yeah.
That was pretty good.
And it wasn't my area of expertise. I'm not a pediatric,
we'll give you
well, you passed.
You
passed. If this were med school, you would pass.
Yeah,
you got better than 50%.
Yeah, we'll grade it on a curve.
Yeah. All right, we're good.
All right, we're going to take one more break. We'll be back after this. All right, this episode is brought to you by Executive Construction.
Established in 1992, Executive Construction is an Orange County-based general contractor which takes a new approach towards room additions, kitchens, bathrooms, and all your remodel needs.
Yeah, they have the capabilities of doing pretty much any kind of remod that you need in your house. They just worked on your brother's house recently.
That's right. They redid my brother's backyard. It was pool, jacuzzi, barbecue. Looks absolutely fantastic.
Yeah, they've got 30 plus years of experience, and they're a trusted contractor in the OC area. So reach out to them if you have any construction needs. Their number is 714-497-7406, and tell them Real in the Field sent you. All right, and we are back with Dr. Tejave Sherifan. We're going to get into some real estate talk. I want to know about what your journey has been with real estate, where you're at, what do you got, future aspirations in real estate?
Yeah, I was really fortunate to be older, like I said before, and kind of be at least somewhat business savvy. When I got to Bakersfield, and Bakersfield being, the glorious place that it was, real estate was very cheap. And even though I was making, not a lot of money that people would think like as a doctor would be in residency, I was making less than 60 grand. I was able to at least buy a condo.
Oh, nice.
So I bought a condo for $145,000 in 2019.
Yeah. Wow.
And thank God, by the time that I left residency, which was 2022, real estate value had gone up a lot. So I was able to flip that for 215.
Nice.
So, and I told all the people that I was in residency with, they were, paying rent and all of this, and you have the risk, you could lose money, but I figured in Bakersfield it was either going to stay the same, or it was going to go up. Yeah. So that was nice. That was a nice little nest egg. And then when I got the job in the city that I'm in now, it took some searching and was able to finally lock in and get a home. Kind of probably a little bit more than I would have liked to in terms of like the HOA. Yeah. And I did 10% down instead of 20%. So I have PMI, which I'm not thrilled about. Yeah. But I wanted to be a little bit more leveraged so that I could stay with more capital, because I'm looking to hopefully try to get at least one rental property every year, most likely realistically one every 2 years.
Okay.
Might have not have been the best choice, but that's what I ended up doing.
Yeah, so you saved some capital. You took whatever the money, the proceeds that you got from your house in Bakersfield, sold it. And just in thinking about that, you would have been paying rent no matter what. Right. Instead of putting money towards somebody else's mortgage, you put it to yourself. Yeah. And from that, you took proceeds from that, bought yourself a place out in Palm Springs. And when did you buy that house?
The Palm Springs house,
Yeah.
I bought that in, I think we closed in January of 2023.
Oh, okay.
Yeah,
Oh, yeah.
so just
Pretty
recently.
recently.
Condo?
Condo, yeah.
Okay.
Condo in a lake community. So that's where the HOA is really high.
Right.
Because I have a man-made lake in the desert. So,
Yeah.
so
Got
that-
beautiful.
yeah.
Beautiful.
So that that really is cuts into the profit. But my mortgage in Bakersfield was $900. It was like
Oh, wow.
$892 or something like that.
Yeah.
And the rent that everybody else was paying was like $700 or $600 or $800. And I was
Yeah.
just telling everybody, I was like, what are you guys doing? And I got it like right when I was able to get 2 paychecks and a W-2 and
Right, yeah.
proof of like bank statements, and I got approved for everything. And it was a no-brainer. I mean, it was.
Yeah, how was that process when you bought your first? So, I mean, that's I'm glad you brought that up, because I think that a lot of people don't understand, just what it takes to have a W-2 compared to, 1099, and what you can do once you have a paycheck, two paycheck stubs, and a bank account. So what was that process like for you when you applied for your loan out in Bakersfield?
It was overwhelming. There was a lot of stuff that I didn't know. Luckily, I had the guidance of like family members, and in particular, like my father, that was like really helpful. He's bought and sold real estate before.
Yeah.
So it was really kind of like monkey see, monkey do. He just told me all the stuff that I needed.
Yeah.
And then when it was a little frustrating dealing with like the underwriter or who the lender. Because I would send him something, and it'd be like, well, I need this now, and then like in the next email, it'd be like, send me the thing that you had just sent me like 2 emails ago, and it's like if you go up on the chain, it's there. And then I realized that for these guys, you got to really make it like. So I just made one email with like my W-2, my 2 statements, some other money that I had from leftover from personal training, like all of the thing that actually helped me a lot, I think, that I was able to get approved for loans was all of my student loans went into forbearance.
Oh, yeah.
Or else like my debt to income ratio, I don't know if I would have qualified, but luckily with like $150,000 worth of school loans, which is relatively light compared to other people, I didn't have a payment coming out of my pocket. So that ended up helping me a lot. But to go back to your question, like it was very daunting. It was a little confusing, and I'm glad I had somebody else that had done it before. That showed me how to do it. Now I feel like I'm a little bit more prepared. I have all my documents already, on my computer. Everything's PDF format. So like I'm ready to go this next time.
Experience now.
Yeah, exactly.
And that's the future plan, is to buy some rental properties now. So you see like what you did out in Bakersfield. What a property can turn into in just a short period of time, and then you're going to try and duplicate that.
Yeah, and obviously I had a really amazing first crack at it, and they're all not going to basically double or give me 50% return. But in terms of what to do with your income, I'm not as savvy in like stocks as I should be. I don't really feel comfortable investing in like VC or like companies as real estate, especially in Orange County, is something that I've seen a lot of people do really well on, and it just makes sense to some extent. So the goal right now, and I probably shouldn't be as in my portfolio, I shouldn't be as interested in real estate as I am, but I'm just getting started. So if I could get a couple starter properties over the next 5 years, that would be great. And I don't know where I'm at yet in terms of, get them and try to cash flow them and keep them, or, and I don't really have any construction background or anything, but the idea of like flips seems really, really, interesting. But it's great when it works out. You buy something, you put a little bit of money in it, you flip it, and in, 3 months you made 60, 80 grand. It doesn't always work out that way. So as of right now, it would be buy something and rent it out. Hopefully it cash flows or it kind of breaks even. And then, maybe down the line, if it's gone up in value, sell it or continue to rent it.
No, it's a good plan. And I mean, thinking about making your money work for you and doing, taking whatever capital that you have, and it's one of the safest places that you can park your money. It's one of the best investments that you can make. Because especially in Southern California, there's always a need for housing. There's always a need for rentals. Just year after year, rental prices keep going up, and there's no better place to do it. So, I mean, it's a good idea.
Having the right plan, but not the right time,
Yeah.
really scares me. So, what do you think your thoughts are? Because you can say you can buy, and over a long enough time, you're always going to be right. But are you, with how high everything has gone?
Yeah, it's tough, especially right now. It's tough to cash flow. It's tough to buy a property, collect rent, and make and just cash flow to a point where you're covering your costs and making a little bit on it. I mean, if your long-term plan, if you can kind of sustain a little bit of a dip in like what your take home is for the long-term goal to be, have this property, have it gain value, and then also at some point cash flow, I think that would be, that's really the only way to do it. Because right now, with interest rates the way that they are and with property values the way that they are, it's hard unless you're putting like 50% down to really cash flow on a $1 million property. And if you're looking at like a 2-unit property in Orange County, $1 million is like your minimum, like the minimum that you're going to get. There are other places that have more growth and have a like lower barrier to entry. Some of the places like on the outskirts of like Orange County, Hesperia, Victorville, things like that. You just got to know what you're getting into, and you got to know what those numbers look like in order to purchase, be able to cash flow, get into places that have like some nice growth, and at minimum can kind of cover your expenses and cover your rent for as long as you can and not lose money.
And that's the next daunting thing is, the difficult thing that's more daunting is like, do I go to some place that's less desirable to live?
Yeah.
And so you don't think that it's going to go up in value as much as it would if you buy something on the coast.
Yeah.
But
true.
buying something in Dana Point, Newport Beach, Laguna Beach, La Jolla, those types of things, Corona del Mar.
Yeah.
Like they're so expensive, and it's so hard to project that. Like, do you really think it's going to keep going up and up?
Yeah.
I mean, places along the coast, they're like $1,100 a square foot. Like, is it going to keep going up to where it makes sense for you to buy something? It's going to go up to $1,500 a square foot, $1,800 a square foot, and the only thing they always say, you can't duplicate beachfront, waterfront properties.
Yeah,
so.
that's true. I mean, that's the, if everybody had the answer to that, we'd all be millionaires. And there's a lot of people that get into, buying properties, rehabbing them, either flipping them or renting them. It's tough to say because nobody can kind of see the future and what these places are going to look like rent-wise and property value-wise. Everyone's trying, kind of just making the best assessment. And I think going into it with the plan of, how you want to get to that goal, I think that's the best kind of way to formulate that path is goal in mind and like the trajectory and how to get that.
Yeah, the two things that I'm looking at, and just like I could get in a place with a lower barrier of entry, and actually let me start with this. Do you feel like rent in areas like that you mentioned, Victorville, Hesperia, Inland Empire, do you feel like 2-bedroom, 3-bedroom, the rent you would say is how much more different than rent in a similar size place here in like Orange or wouldn't you say they're relatively close? Like
it's so tough. Every area has its own. Every area has its own kind of like price. I mean, I leased a place in Rancho Mission Viejo for almost $5,200. 3-bedroom, 2-bath. I rented a 3-bedroom, 2-bath here in Orange for $3,500. I mean, it's like almost like a $2,000 swing in price. And if you kind of took the distance from where the house is compared to the coast, I mean, it's about the same distance. It's just one's down and all the way in South Orange County, and the other one's here near the Circle. So it's hard to really kind of put a hard like this is where prices should be based on kind of where they're at to the coast. But that's all to say that places like Hesperia or places like Victorville, you can purchase them for significantly less. And so the amount that you're going to be out monthly compared to what you're going to be bringing in monthly might be like the gap might be smaller, you know what I mean? And maybe there won't be that big significant like increase in value like there would be in Orange County, but it's all just a matter of how much you want to be out, you know, and if your plan is to purchase every 2 years or every year, what that looks like with your income and how much you have and how much you want to allocate towards that. It might be that what you're bringing in, you're better off purchasing, you know, places like that you can put less down and cash flow immediately compared to saving everything and buying something in like Corona Del Mar or any of the places that you're talking about, and just all your money's allocated towards that. You're not going to be cash flowing, and on top of it, you're just going to be, you know, you might be upside down on your rent for a little bit until you get to a point where, you know, you cash flow better, or you put more money down in order to cash flow, and then you're just kind of, you know, out that capital. You know what I mean?
No, that was exactly my question was, you know, cash flow in those lower property cost areas, and you're cash flowing sooner, but the chances of you doubling up is a lot less likely, whether or not you get a place on the coast where you probably won't be cash flowing. But if you do go to flip or you do go to sell, there's a chance you could double up. There's a chance, or you know, something that you bought for 1.5, 2 million is going to go for 2.8, 2.9. Whereas if you buy something in those other cities for 6 for 500, at most you might be able to get 700, 800, and you know, you made a nice little chunk, but you're not
the significant amount like if you were to just buy something like that. I think that would go back to where your game plan is and what you want to do, and are you looking to get out. If you're looking to purchase, make a big profit and get out, then for sure there's no growth like Southern California, coastal Orange County, you know, as close as you can to the beach. There's going to be no better place to do that. If it's, you know, buy and hold and just have long term, you know, there's like an old adage of, you know, however many doors you can get, you know, if that's the objective, then, you know, maybe some of those other places might look a little bit more desirable.
All right, here we go. We're going to ask one last question. Let's put a bow on it. Let's land the plane. Send us out.
Yeah.
If someone wants to be a doctor, what do you recommend? What advice would you give them?
That's one of those annoying things where, like, I'm going to answer a question with a question, and it's why. You got to know your why. Just like any big decision in life. What I've seen with a lot of physicians, it was hard family upbringing that you're going to do really well in school, you're going to get good grades, you're going to go to a 4-year college, and then you're going to med school. And the kid just kind of gets in the grind and gets in the motion. And it's just like, I get good grades. That's what I do. I ace tests. I kick butt academically. What's really interesting about becoming a physician is it's so much more of a people business, and it's not as cut and dry as just read something and do well on a test. You have to really be into interacting with human beings, understanding the human element, and that has to be something that you look forward to. Like the payoff has to be the joy that you get doing an act of service for somebody. So know your why is the biggest thing. Are you getting into it because you're just really smart and you do really well in school, and just that's what people around you are telling you that you should do, and everybody in your family is going to respect the fact that you're a doctor and you're going to have this amazing title? Or is it that you really want to be in a game of, not a game, but be in a job that's, you know, literally a matter of life and death, and you want to interact with people?
It's pretty good.
Love it.
Pretty good. All right, well, that's a good note to go out on. So that is this week's episode of Real in the Field. Thank you to Dr. Tejave Sherifan. We appreciate you being here. It was really cool hearing your story, your story in the medical field and how you got into it, and your journey all along. So thanks for coming. Thanks for being on, and we'll catch you guys next week with a new episode of Real in the Field.